Welcome everybody to the final installment of the conversation on TMD. So these are my details if you didn't get them on the other slide. And that's what our practice looks like in North Essendon. Sleep apnea. Sleep apnea is certainly a component of TMD. It's not always the answer, but it is something else that needs to be looked at, because if you do have sleep apnea, then that could actually be the reason for your TMD. As I said before, TMD is a very complicated topic, so we have to try and find out what the issue is. So here's a questionnaire that you'll find on our website, and if you're answering yes to any of these questions, then a sleep test is a very good idea, not to rush to just make a normal splint, because if you do have sleep apnea, then there's a different dental device that we make to help you with your sleep apnea, but also the same device will help you with any grinding or clenching issues that you have. So have a look at that, have a look at those questions, and yeah, if you have any problems, well then a sleep test is required to work out what's the next step for you. TMD, 80% of TMD patients are female, 20 to 25% of the population seek professional care, and 5 to 10% of the population require advanced care. People say, why is it females so many? One reason is purely because females do search for treatment, whereas males are more inclined to not seek treatment and just put up with the pain. I think that will slowly change with time as males start opening up and start talking more about issues that do affect them. Splints, just a quick conversation on splints. If you Google splints, you come up with 100 different types and shapes of splints. Some people believe that their splint is the best splint. And I can tell you, I see a lot of different splints, and sometimes the splint itself is not the answer. I don't think there's any one splint that's the perfect answer. I do like just making a flat plain splint, which is this one here that just covers all of the teeth. But in making that, some people find that's too bulky, so we have to reduce it in size. Some people like it tight, some people like it loose. It pretty much is just making a splint that the patient finds comfortable, so that you actually do wear it at night time. So there's many different types of splints that are made or can be made. Splints do help in... Splints aren't the answer to everything. Sometimes miraculously you make a splint and the headaches and migraines and the sore jaws all goes away, and if that's the case, then it's just purely because the splint is decreasing the pressure on the muscles, on the facial muscles, decreasing the pressure on the teeth. But they can't get rid of a lot of other issues. So how do they work? A splint actually, it is controversial how it works. There's various theories as to why they do work. One is that when you do bite down on a splint, you don't bite down as hard because you're biting on a piece of plastic. No different to when you eat an olive and the olive has a pip in it, and you don't keep biting down on the pip because you're scared of breaking your teeth. So that's what it means in change in proprioception. Habits, it does make you aware that you are grinding and clenching. So if you do wear a splint at night time, then you'll probably find you won't do it as much during the day. Occlusion, if your bite is incorrect, like when you bite down and your teeth aren't biting properly, that can give you pain as well. So wearing a splint, the teeth aren't involved in the bite anymore, and so your jaw's just able to open and close nice and straight. But the theories are inconsistent. Sometimes, as I've said in the previous videos, is that a splint is made and it's called a diagnostic splint, meaning that we'll give you a splint, we'll have a look and see what effect it has, before we can think about what the next line of treatment is. So what do splints do? They decrease the loading of the joint. They can reduce facial pain and headaches because the muscles of the face aren't as strong when you're biting down onto a splint. And if that's your problem, it's a muscular problem, then it will improve your TMD symptoms, and it definitely protects the teeth. And for those people who do grind and clench a lot, then a splint is a very good idea because it will protect all that expensive work that you've had done to your teeth. What they don't do is, as I've shown on previous videos, where the little disc in the TMJ joint is out of place, just making a splint will not recapture the splint. They don't eliminate bruxism, where you're just grinding your teeth really badly. That's more a habit, or what's called a dystonia, where the muscles are just working without you even realizing that you're working. So a splint doesn't stop that, but you can brux your teeth, and a splint will protect your teeth, reduce the muscle load, take pressure off the joint as well. But bruxism, continued bruxism, is where Botox plays a part in that, and I'll talk about that very soon. It does produce an ideal muscular-occlusal relationship. As I said, having a splint in place, if your teeth are not in the right position, a splint now will not allow the teeth to interfere and allow your jaw to open and close nice and straight. Establish vertical dimension, meaning if you've completely worn out your teeth, it adds back that distance again, but more investigation needs to be done on that part of it. In our practice, we've made a lot of splints. There's not many practices that have made that many splints, so I do believe that I'm pretty good in the conversation of splints and the good and the bad of them and what different people do require. Headaches. The National Headache Foundation classifies approximately 90% of all headaches as muscle contraction headaches. So if that's the case, then a splint can help you with your headaches. That's why people become addicted to their splints, because the headaches go away. Botox. Let's talk a little bit about Botox and where it fits into the conversation of TMD. These are the muscles that do play a part in Botox. There's also the muscle down here called the Masseter muscle. That's actually the major muscle when you grind and clench your teeth, or when you eat and chew. Then when your teeth touch, the Masseter muscle connects with this muscle here called temporalis, and the other muscles around the face. That's why the cosmetic areas are actually TMD areas as well. So if we can reduce the strength of these muscles using Botox, then you're not going to have as many problems. And if you are a bruxer and you can't stop yourself doing it, then Botox is definitely the treatment of choice for you, because if we can weaken the muscles and stop them moving around and stop them functioning so much, then you'll find that you won't brux as much either. So just with a lot of bruxing and grinding, that you can see how much you can build those big Masseter muscles up. It's like taking the muscles to the gym every single day. Every night you grind and clench, during the day you grind and clench, and you can see that Botox reduces the size of those muscles. They are a lot weaker now, and it completely can change the way somebody also looks. And this is just another example of people who do grind and clench and what Botox can do to weaken the muscles. So reported uses of Botox, there's TMD, there's masseteric hypertrophy, that's what I just showed you, where the muscles are too big. Bruxism is where the muscles just keep functioning and you can't stop it. Mandibular spasm, that's meant to have an N. Periodontal surgery, if you're grinding and clenching your teeth a lot, you're putting a lot of pressure onto your teeth, which puts pressure onto the ligament that attaches the tooth to the bone. So some people, just with grinding and clenching, can destroy the bone around the teeth and then just lose their teeth as well. And that's exactly the same with implants. The muscle pressure, if we can reduce it, then that helps implants as well. Orthodontic surgery, gummy smiles, smoker's line. You can see that if we have a look at from a cosmetic point of view, people go and get Botox done for cosmetic reasons, and you don't need much Botox for the muscles of the forehead or around the nose. They're not big muscles, so you don't need much Botox. But the masseter muscle and the temporalis muscle themselves can take 10 to 20 units. This is just a standard, the minimum that you would put into the masseter muscle. But there's a lot of times where we put 10, 15 or even 20 units. So that's why when we're doing Botox for TMD problems, it is expensive, because we are basically using the entire bottle, and we can even open up another bottle and use more. So that's why when somebody comes to us with Botox for TMD, then it is a lot more expensive than just for cosmetic reasons, because the major muscles involved in the grinding, clenching, headaches, migraines are large muscles that require larger units of Botox to be used. So many cases with persistent orodental pain show no radiographic or clinical evidence of decay, periodontal involvement, periapical lesions, and the pulp test shows that the teeth are vital. So what that sentence is saying is that just because you have a toothache, it doesn't mean that it's a tooth. And the problem is that the cause of the pain can be a mystery. But hopefully from this video series that I've taken you through, I've tried to keep it extremely basic, but I've also tried to show you all the different things that we at FirstBite Dental would go looking for. And also the other important thing is, because it does involve a lot more structures of the ears and the nerves and the brain, etc., that we do need a team to treat people's TMD. It's not a one-person show. Sometimes it is, but sometimes it requires different specialties to help us diagnose the problem. And the challenge is finding out what structure is causing the pain. So there's my details. Thank you very much for listening. It's a very big topic. I've tried very hard to keep it exceptionally short, but this topic, when I do give this lecture to dentists, is a full 2-day lecture, and I've tried to give it in short bursts so that we don't bore you too much with it. So thank you very much.